So, welcome to the Kanski lecture series, and this is going to be the chapter 14, part 2. And in this part, we were discussing about the fluorescent angiography. Now, we are going to discuss about the different phases occurring during the fluorescent angiographic phases. So, fluorescein enters the eye through the ophthalmic artery, passing into the choroidal circulation through a short posterior ciliary artery and into the retinal circulation through the central retinal artery. So basically, the retina has a two blood supply. So there is a retinal supply and there is a choroidal supply. So first, it will enter the posterior ciliary artery into the choroidal circulation and through the central retinal artery into the retinal circulation. The choroidal circulation fills about 1 second before the retinal. Precise details of the choroidal circulations are not discernible, mainly because of the rapid leakage of the free fluorescent from the choriocapillaries. Because their choriocapillaries has a fenestration, so that is why the fluorescent leak into the choroid early. So that is why the choroid is not best investigated in a case of a fluorescent angiography. Melanin in the RP cells also block the choroidal fluorescence. The angiogram consists of the following overlapping phase. So first is there is a choroidal phase, so which is a pre-arterial phase, which typically occurs 9 to 15 seconds after the dye injection. So just after you injected the dye, after the 9 seconds, it starts the choroidal phase, longer in a patient with poor journal circulation, and is characterized by the patchy lobular filling of the choroid due to the leakage of a free fluorescein from the fenestrated choriocapillaries. So there will be like a patchy choroidal filling. A cilioretinal artery, if present, will fill at this time because it is derived from the posterior ciliary circulation. And also, if there is a posterior cilioretinal artery, it will fill during the choroidal phase. Arterial phase starts about a second after the onset of a choroidal fluorescence and show the retinal arteriolar filling and the continuation of the choroidal filling. So in the arterial phase, the artery started to get filled. In the atriovenous or capillary phase, show the complete filling of the arteries and capillaries with early laminar flow in the veins. So in the atriovenous phase, the arteries are being filled, the capillaries are being filled, and also there is a laminar flow in the veins in which the dye appears to line the venous wall, leaving an axial hypofluorescent strip. This phenomena reflects the initial drainage from the posterior pole capillaries filling the venous margin, as well as small vessel velocity profile with faster plasma flow adjacent to the vessel wall where the circulation cellular concentration is lower. So because the peripheral plasma concentration is faster, so that is why it is basically it feels that the lamina is being fluorescent. Then there is a venous phase. Lamellar venous flow progresses to complete filling with late venous phase featuring reducing arterial fluorescence. Maximum perifoveal capillary filling is reached at around 20 to 25 seconds in a patient with normal cardiovascular function, and the first pass of the fluorescent circulation is generally completed by approximately 30 seconds. So after the atriovenous phase, there is a venous phase in which there is basically the complete filling of the venule vascular system, and it takes about 20 to 25 seconds to complete. So this all phase almost takes about 30 seconds to get completed. Then there is a rate recirculation phase, demonstrate the effect of a continuous recirculation, which is included. There is a recirculation, there is a dilatation and elimination of the dye. With each succeeding wave, the intensity of the fluorescent becomes weaker, although the discs show staining. Fluorescence is absent from the retinal vasculature after about 10 minutes. So after 10 minutes, it completely get absent from the retinal vasculature. So this is a fluorescent access to eye. So this is an ophthalmic artery. So first it goes to the short posterior ciliary artery to the choroidal circulation, and then it goes to the central retinal artery. So this is a normal fluorescent angiography. A is showing the choroidal circulation. So this is a patchy filling of the choroid, and also there is a the cilioretinal artery is being filled. So also this B is showing us an early arterial phase, so you can see that it is an artery is being filled up, and this is showing us atriovenous phase. You can see that there is like arteries are being filled, and there is a small lamellar flow um, starting in the veins. And D is showing early venous phase, and F is showing us a mid venous phase, and early venous phase showing a marked lamellar venous flow, mid venous phase showing almost complete venous filling, and late circulation phase showing weaker fluorescence with staining of the optic disc. So the dark appearance of the fovea. So very important, why the fovea appears dark. The dark appearance of the fovea is caused by the three factors: absence of blood vessels in the foveal avascular zone, blockage of the background choroidal fluorescence due to the high density of the xanthophyll at the fovea, blockage of the background choroidal fluorescence by the RPE cells at the fovea, which are larger and contain more melanin and lipofuscin than elsewhere in the retina. So there are three causes that basically the fovea appear dark in a case of a fluorescent angiography. So one is that basically there is a foveal avascular zone, because the fovea at this stage is having no vessel, so that is why there is the appearance of the fovea is dark. Second is that there is a very high xanthophyll pigment at fovea, which is blocking the choroidal fluorescence. And number third is basically the RPE cells at the fovea are larger, taller, and contain abundant melanosomes. Also, that is why there is a blockage of a background choroidal fluorescence. So this is an anatomical causative factors of the dark fovea. So there is a xanthophyll pigments, there is RPE cells with an abundant lysosomes, and also there is no vessels here. So this is a foveal avascular zone. So FAF image showing the optic disc drusen fluorescent autofluorescence is showing us there is a whitish material in the disc, which is due to the optic disc drusen. So hyperfluorescence. So there are certain causes which causes the hyperfluorescence either of any lesion or either of any vessels. So there is a one thing called autofluorescent. So autofluorescent is basically when you have not put the fluorescent into the eye, but still you place the filters. There are certain material which have a fluorescent like property, so these are known as autofluorescence. So autofluorescent compounds absorb blue light and emit yellow-green light in a similar fashion to fluorescent but weaker. Autofluorescence can be detected on standard fundus photography with excitation and barrier filter both in place. So basically, you just did not inject fluorescent, but instead put the excitation and barrier filter on the place. Some modern digital cameras have enhanced autofluorescence detection capability. Thaw imaging is most effective with scanning laser ophthalmoscopy. Autofluorescent lesions classically include the optic disc, nerve head drusen's, and astrocytic hematoma, but with increased availability of the high sensitivity imaging, pattern associated with a wide range of a posterior segment pathology have been characterized. So there are certain lesions like optic nerve disc drusen, astrocytic hematoma, they have properties of autofluorescent. So next there is the pseudofluorescence. So pseudofluorescence or false fluorescence refer to the non-fluorescent reflected light visible prior to fluorescent injection. This passes through the filters due to overlap of the wavelength passing through the excitation then barrier filter. It is more evident when the filter are wearing out. So when the filters are not working properly, so what happens is sometimes there is a reflection of the material even you without any fluorescent material being in placed. So this is known as a pseudofluorescence or false fluorescence. So the increased fluorescence may be caused by the enhanced visualization of a normal fluorescent density or an increase in fluorescent content of the tissue. So so there are two causes that it can cause increased fluorescence. Number one is that there is a increased visualization of the fluorescent. Next is that there is an increased fluorescence in the content of the tissue. Next is that the hyperfluorescence can be caused by window defect, pooling, leakage, and staining. So these are all things which can cause us a hyperfluorescence on a fundus angiography. So window defect is caused by the atrophy or absence of RPE as an atrophic age-related macular degeneration, a full thickness macular hole, RPE tears, and some druseness. This result in unmasking of a normal background choroidal fluorescence characterized by a very early hyperfluorescence that increases in intensity and then fades without changing size or shape. So basically, the window defect occur when there is an RPE atrophy. So when the RPE is being atrophied, so there is a disruption in the outer blood retinal barrier. So that is why one can see the fluorescence leak into that space, and you can see that there is a hyperfluorescence of that area, and it appear as a hyperfluorescence which will increase in intensity, means that it will increase in brightness, and but it will fade away without changing size and shape. So we can see figure 14.12b and c. So this is hyperfluorescence. So you can see that there is an atrophy of the retinal pigment epithelium at that side, and you can see the background choroidal fluorescence. So hyperfluorescence caused by window defect associated with dry age-related macular degeneration. A is showing dramatic representation. B and C show the fluorescent angiographic appearance. So you can see that there is a hyperfluorescent area in a case of where there is an RPE is being degenerated. So it occurs in a case of a macular degeneration when there is a hole, or there is some kind of RPE tears or druseness. Next is a pooling. Pooling is an anatomical space occur due to breakdown of the outer blood retinal barrier. RPE tight junction. In the subretinal space, CSR, there is characterized by the early hyperfluorescence, which as the responsible leak tend to be only small, slowly increase in intensity and area. The maximum extent remaining relatively well defined. In a sub RPE space, as in pigment epithelial detachment, this is characterized by the hyperfluorescence that increases in intensity but not in size. So pooling is occurring when there is a subretinal fluid, something like that, because of the leakage of the vessels in a case of in the retinal arteries. So what is happening that there is a breakdown of the tight junctions, so that is why there is a leakage of the material inside the subretinal space. So what is happening, it will the fluorescence will increase in intensity as well as in size, but after sometimes the size become constant. So in the case of a window defect, the size was same, but in a case of a pooling, just intensity was increasing, but in a case of a pooling, there is an increase in intensity and increase in size as well. Whereas in a case of a sub RPE, like a pigment epithelium detachment, pooling will occur, but the size will not increase and the intensity will increase. So we can see there hyperfluorescence is caused by the pooling of a dye in the subretinal space in a central serous chorioretinopathy. A is showing diagrammatic representation, B is showing fluorescent angiographic appearance. So you can see that the hyperfluorescence is increasing in size and intensity like a smokestack pattern. So leakage of a dye is characterized by the fairly early hyperfluorescence increasing with time in both areas and density. It occurs as a result of a breakdown of an inner blood retinal barrier. So leakage occurs when there is a leaking of like a retinal arteries, like whenever there is a disruption in an inner blood retinal barrier. So dysfunction or loss of existing vascular endothelial tight junction, as in background diabetic retinopathy, retinal vascular vein occlusion, cystoid macular edema, and papillary edema. So in that case, when there is a disruption of the endothelial junction, like in a diabetic retinopathy, RVO, macular edema, and papillary edema, leakage of the dye can occur. So it is basically increasing in both areas and intensity. Primary absence of a vascular endothelial tight junction, as in CNV proliferative diabetic retinopathy tumors and some vascular anomalies such as Scott disease. So it can also occur in a case of like a CNV, proliferative diabetic retinopathy, tumors, and some vascular anomalies like Coats disease. So we can see figure 14.15. So this is a 14.14 hyperfluorescence caused by the pooling of a dye in the subretinal epithelium space in the RPE detachment. So whenever there is an RPE detachment, A is showing diagrammatic representation, B and C is showing the fluorescent angiographic appearance. 14.15 showing the causes of the hyperfluorescence due to leakage. A is showing cystoid macular edema, so you can see that there is a leakage of the dye. There is a hyperfluorescence area which is increasing in size and intensity. B is showing proliferative diabetic retinopathy, leakage from the extensive vessels around the disc. So this is the leakage of the vessels. And next is a staining. So staining is basically when the tissue is being dyed. Like, staining is a late phenomena consisting of a prolonged retention of the dyes in entities such as drusen, fibrous tissue, exposed sclera, and normal optic discs. So it can also staining can also occur in a case of a normal optic disc, in a case of a drusen, in a case of a fibrous tissue, in a case of an exposed sclera as well, and is seen in the later phases of the angiogram, particularly after the dye has left the choroidal and the retinal circulations. So next is the causes of hypofluorescence. So the hypofluorescence mean when there is a blackish discoloration because of the absence of the fluorescein. So the reduction or absence of a fluorescein may be due to optical obstruction. So there is something that is obstructing to take the vision of the area, like some kind of hemorrhage of a normal fluorescein density or inadequate profusion of tissue filling defect. So masking of the retinal fluorescence, pre-retinal lesions such as blood will block all the fluorescence. So for example, if there is a blood that is vitreous hemorrhage that is obstructing the vision, so that area will appear hypofluorescent. Masking of the background choroidal fluorescence allow persistence of a fluorescence from the superficial retinal vessels, for example deep retinal lesion, for example intraretinal hemorrhage, subretinal or sub-RPE lesions, for example blood. When there is an increased density of RPE like congenital hypertrophy, choroidal lesion, for example nevus. So whenever there is some lesion that is can obstruct the vision of that area, it causes a hyperfluorescence. So for example there are if the masking of the background choroidal fluorescence occur because there is RPE hyperplasia, if there is some kind of choroidal lesion like nevus, if there is some kind of the retinal hemorrhages, it can cause the masking of the background choroidal fluorescence. If there is filling defect because of the area of a capillary non-perfusion, the vascular occlusion, which may involve the retinal arteries, veins, or capillaries, capillary dropout, or choroidal circulation, FA is sometimes used to demonstrate optic nerve head filling defects as an anterior ischemic optic neuropathy. So whenever there is some problem in the vessels, so that vessels are very narrow and it is not draining the area, it causes that side of the area to be hypofluorescent. Loss of vascular band is in myopic degeneration and choroidemia. So this is a let's see figure. So this is a causes of hyperfluorescent. For example, if there is any pigment present, if there is any xanthophyll present, if there is a hyperplasia of the RPE, it can cause the hypofluorescence. If there is any abnormal material present, if there is any exudate present, if there is a lipofuscin present, it will causes the black back disc hypofluorescent. If there is any blood which can be intra subretinal, pre-retinal, it can cause the blockage of the background fluorescence as well. So this is a hypofluorescent masking of all signal including from the retinal vessels by pre-retinal hemorrhage ILM. So this is you can see that there is a pre-retinal hemorrhage and you can see on fluorescent angiography it appears as a dark. So this is a hyperfluorescence blockage of the blood by sub and intraretinal hemorrhage showing a persistence of signal from the retinal vessel. A is showing clinical appearance in a patient with age-related macular degeneration, and B is showing fluorescent angiographic appearance. So you can see that there is a blood here and there is a hypofluorescence area because of the blockage of the background fluorescent. So, systemic approach to fluorescent angiography analysis. A fluorescent angiogram should be interpreted methodically to optimize diagnostic accuracy. Clinical findings, including patient age, gender, should be noted before assessing the image. So, one thing you should identify patient name and age and gender. Note whether image of the right, left, or both eyes have been taken. Comment on any color or red-free image or on any pre-injection demonstration of the pseudo or autofluorescence. Looking at the post-injection images indicate whether the overall thinning or timing of filming, especially arm to eye transient time, is normal. Briefly scan through the sequence of images in time order for each eye in turn, initially concentrating on the eye with the greatest number of shots, as this is likely to be the one about which there is a greater concern. On the first review, look for any characteristic major diagnostic, especially pathognomic feature, for example, lacy filling pattern or a stack pattern. So you can see some early findings which are characteristic of any lesion, for example, case of a smokestack. Go through the run for each eye in greater detail, noting the evolution of any major feature found on the first scan, and then providing a description of any other finding using the methodical consideration of the causes of the hyper and hyperfluorescence set out above. So that's it for the acquired macular disease part 2. See you in the next lecture.